now we're going to talk about the abdominal X-ray or the abdominal radiograph, why we use it, where we use it, what are the indications, and I'm going to go through a few X-rays of abdominal pathology. So, why the abdominal X-ray? Well, it's readily available. You can do an X-ray really quickly, not like a CT or an MRI scan. It's cheap compared to CT or an MRI. You know, it costs a few pounds as opposed to hundreds of pounds. It does involve radiation, but it's a much lower dose than the radiation that a CT is associated with. It's often the only study required to make a diagnosis, but this isn't the case in all situations because it can sometimes be regarded as a blunt tool, and as CT becomes much more available, abdominal X-rays are being used less and CT is being used more because it just gives you much more information. It's not useful in all situations. It shows the soft tissues, but not in any way near the detail that a CT or an MRI would show. And if the patient's stable enough to go to CT, I think that's what is normally done these days. A patient goes straight to CT. So there are some indications for abdominal X-ray. Non-specific abdominal pain is one. It might show something. Small and large bowel obstruction is probably the most common indication for an abdominal X-ray because it will show bowel obstruction. It may not show the cause, but that can be elucidated later on, but it will confirm a clinical suspicion. Palpable mass is another indication, but I think most people are going straight to CT these days, and also renal colic, where you might see a stone, but remember about 5% of renal stones are not radio opaque on an abdominal X-ray, i.e. they can't be seen on an abdominal X-ray, and now we have very low dose CT KUB, KUB standing for kidneys, ureters and bladder, which is only a little bit more radiation than an abdominal X-ray and will show you a stone much more readily than an abdominal X-ray, and it will also show whether that stone is causing a hydronephrosis or a blockage of the kidney, which can become an emergency situation. So an abdominal X-ray, it lacks the symmetry of the chest, and symmetry is an important tool in interpreting X-rays because if you see something on one side that isn't on another, then it might be abnormal. But abdominal X-ray lacks that symmetry because, of course, you'll remember from your anatomy days that the abdomen isn't symmetrical. You've got the liver on the right, the spleen on the left. Vessels are in differing places. But you can see several solid and hollow organs, but not in any great detail, I have to add. So here is an abdominal X-ray. You can see probably most starkly the bones. You've got your pelvic bones, you've got your lumbar vertebrae, transverse processes. You can see the tops of the heads of the femurs, and you can see gas, which is translucent. So remember from the X-ray lecture, if you go through less dense, if the X-rays go through less dense material, it's more dark. If it goes through dense material, the X-rays are attenuated, it becomes lighter. So gas, as we know, is not dense at all, so you can see sort of lucent or less dense gas within bowel. Here's gas within bowel, but it's surrounding a lobulated structure, which is feces within the descending colon. So you see lumps of feces within the descending colon. Here's gas within the rectum. You can see that sort of lucency, large amount of gas within the rectum. You can see the outlines of some solid organs. You just about see the right kidney there. You can see the left kidney there. You can see the psoas shadows, which are actually quite important because if the psoas shadow, the lateral border of the psoas, becomes blunted, it implies pathology. And you can try and figure out how and what that is with the CT. You can see the sacroiliac joints. Sometimes inflammation can mimic abdominal pain. You can sometimes see the lower edge of the liver. You hardly ever see the spleen unless it's really enlarged. Again, I've shown you the kidneys. The bladder you can sometimes see because it's outlined by fat, but you can't see the pancreas, you can't see the adrenal glands, and you can't see ovaries or uterus, unless the uterus is calcified, such as in fibroids. The abdominal X-ray is really important for hollow organs, the bowel essentially. You can see the stomach occasionally, particularly if it's distended with air. You can see small bowel loops, which are the loops occupying the central abdomen. They're less than 3 centimeters in diameter, and they are distinguished from large bowel because they have these transverse shadows, which are called valvulae conniventes. You may have come across them before. Whereas the large bowel, which is around the periphery of the abdomen, contain haustri, which are incomplete, which incompletely traverse the bowel. This distinction is important if you're going to differentiate from small versus large bowel obstruction. So when you're presented with an abdominal X-ray, you can do the preliminary assessment, usefully divided up into your A, B, C, D, E, and Fs with an S. A is for adequacy. Is it over-penetrated, under-penetrated? If it's over-penetrated, it will be either very bright. Can you see the bowel? Look for calcification, as most significantly renal calcification, which might be causing abdominal pain. Look at the densities, the soft tissue densities. Look at the edges of structures, see if they're obscured by pathology. Look for fat planes. Again, these can be obscured by pathology. And you can look at skeleton, which, as I've said before, can mimic abdominal pain. This is a systematic way of going about things, but also correlate with the clinical picture. So, you know, avert your eyes to the appropriate regions of symptoms. So for example, if your patient's got flank pain, then concentrate on the kidneys, look at the root of the ureters, trying to pick up any calcifications which may represent calculi. So let's go through some of these assessments. So adequacy first. Look at it. Look at the film. See whether it's a standard AP view or a supine view. We don't really do erect abdominal X-rays anymore, but they did have a use when you were looking for fluid levels within bowel, which is a sign of obstruction. You should do an erect chest X-ray if you're suspecting intra-abdominal bowel perforation, because you'll see air underneath the hemidiaphragms if there's a bowel perforation. The air has leaked from a hollow viscus and then accumulates under the hemidiaphragms on an erect patient. Make sure the film has included the pubic symphysis and the hernial orifices where you might see a hernia. So following on from that, what are these arrows pointing at? This is an erect chest X-ray. These arrows are pointing at this lucent, curvilinear lucent region under the right hemidiaphragm and left hemidiaphragm. So this patient has had an abdominal perforation. The air is now accumulating under the hemidiaphragms on an erect chest X-ray. So yeah, interestingly, the chest X-ray is indicated in acute abdominal pain, more so than an abdominal X-ray, which may not show perforation. So this is an erect abdominal X-ray. We can see these very large loops of gas-filled bowel indicating obstruction. We can see that there is an air fluid level here. You can see the fluid level and the meniscus, and you can see that this is small bowel obstruction because the bowel that's obstructed here has got these valvulae conventi which traverse it completely. So, small bowel obstruction and probably a very dilated cecum. So air in the abdominal cavity implies perforation, unless there's been a recent operation or even a laparoscopy where they inflate the abdominal cavity with gas. There's a sign called Wriggler's sign. It's where the bowel wall becomes much more conspicuous because you've got air on the inside of the bowel and you've got perforated air on the outside of the bowel wall, and that air opposed to the bowel wall makes the bowel much more conspicuous, the bowel wall much more conspicuous. Normally you only see the inner aspect of the bowel wall because the outer aspect just merges with the surrounding fat. You may see the outline of the falciform ligament outlined by air, but if there's any element of doubt, you can get an erect chest X-ray, but in these days a CT, which actually is one can get very quickly. So this is a shocking X-ray. What do we think is going on? It almost looks like a chest X-ray, doesn't it, with the heart and the lungs? But it's not. It's the heart and the lungs are up here. So that's the mediastinum. This is the lung. These are the hemidiaphragms. There's been a huge intra-abdominal perforation, which has basically displaced the liver edge downwards. And these are small, and these are bowel loops which have also been displaced towards the centre. You don't see this very often, and I wonder whether this is iatrogenic. Is this immediately after a laparoscopy, because there is just so much air in the abdominal cavity. This is Wriggler's sign, air within bowel and air outside bowel, making that bowel wall look much more conspicuous. Normally the bowel wall just merges with the surrounding fat, and you can see it also in this bowel here. So there's lots of free gas enveloping the bowel. This isn't perforation, this is an example of the haustra. They're sort of incomplete. I mean, they look sort of complete here, but actually they are essentially incomplete transverse folds within the large bowel, and this is within transverse colon. And compare this bowel fold to these small bowel folds, which are actually complete, and they're much smaller and they're more centrally placed. So these are valvulae conventi within the small bowel. So large bowel, small bowel. You can tell the difference because of their anatomical location. This is at the periphery, as you know, the large bowel is on the periphery of the abdomen, and this is more central with these complete valvulae conventi. Calcification is important to look for on abdominal X-ray. Many causes includes costal cartilage calcification, which you see in older patients. It's incidental, don't think it's pathology. Phleboliths, very common, even in young patients. There's just calcification of the veins, particularly in the pelvis. They can be mistaken for ureteric calculi. And vascular calcification, again very common the older you get. But actually really important to look for in the aorta, because in an aneurysm the aorta is often calcified, and the calcification outlines the wall of the aorta, so you can actually assess that it's aneurysmal. But the calcification that you can see that might be pathological calcification are renal calculi. So 90%, actually 95% of 90 to 95% of renal stones are radiopaque, i.e. they can be seen on an abdominal X-ray. Gallstones, well, only 10% are radiopaque. So if you don't see gallstones, it doesn't mean that the patient doesn't have gallstones. Lymph node calcification is incidental, more common the older you get. Pancreatic calcification implies chronic pancreatitis, and you can just see it conform to the orientation of the pancreas, and it's a very distinctive punctate nodular calcification. And spleen, you get calcification. It could be previous trauma, it could even be previous infection, So splenic calcification, think about previous infection. You can have appendicoliths, which are calcifications blocking the orifice of the appendix and causing appendicitis. Not often seen, but if you do see a calcification within the right iliac fossa and the patient's tender on McBurney's point, then essentially it supports your diagnosis of an acute appendicitis. Bladder wall calcification, less often seen these days, but associated with TB and schistosomiasis. Seminal vesicle calcification you see in diabetics. Very distinct ovoid or spherical calcification is seen within fibroids occupying the uterus. And dermoids dermoids show calcification, and when you have dermoid cysts in the ovaries, and actually they show a calcification which looks like teeth. So dermoid cysts actually contain teeth and other stuff like skin and hair. So let me show you some examples. Here is costal cartilage calcification in an elderly patient. You can see it's curvilinear occupying the costal cartilages. You can see the ribs laterally, and this is costal cartilage calcification. It's very peripheral. It doesn't cause any pain. This is a magnified view of what part of the abdominal X-ray. Well, these bones should give it away. These are the superior pubic rami. This is the pubic symphysis. These are ovoid pelvic calcifications with a little bit of lucency in the middle if you look carefully, and these are what we call phleboliths, so seen very often, of no clinical significance. So these are very interesting multifaceted calcifications under the right subcostal margin. This is costal cartilage calcification, to be ignored, but these aren't to be ignored. What do we think these are? Well, under the right subcostal margin, they are gallstones. Okay, they're very distinctive gallstones. You can almost imagine a gallbladder containing these gallstones because they conform to the gallbladder cavity. Seminal vesicle calcification in diabetics, bilateral. Young patient with right iliac fossa pain. You see this. This is an appendicolith. It's not a ureteric calculus because it's a little bit too lateral, but the clinical signs and symptoms support this being an appendicolith. This is a nice X-ray just showing that things don't occur on their own. You've got some gallstones here in the right upper quadrant underneath the subcostal margin, and these are mesenteric calcifications in an elderly patient. They're just distributed throughout the mesentery, of no significance, but may imply previous infections such as TB. This is a very nice example of this sort of irregular punctate type calcification on a female patient. You know, it's fairly well defined, it's extensive. These are multiple calcified fibroids within the uterus. You can see them arising from the pelvis. There's a right-sided hip replacement, and there's some degenerative disc disease with disc space narrowing. But this kind of calcification, consider calcified fibroids. This is an absolutely beautiful example of a patient with right iliac fossa pain, young female patient. What do we think these look like? Fairly obvious. These are teeth. These are teeth within a dermoid cyst. Very, very characteristic. You can see that they are in the right iliac fossa. This is the pelvic inlet. This is the lower aspect of the sacroiliac joint. This is the sacrum. This is in the right iliac fossa. This lucency is just overlying bowel. Now here's where your anatomy comes in. This is calcification. You can see it's sort of irregular punctate calcification just to the left of the L1 vertebral body, and also the bottom part of it is to the right of the L2 vertebral body. It's obliquely orientated. It's calcification within an organ. What do you think it is? It is pancreatic calcification in a patient with chronic pancreatitis. Okay, so that was C for calcification. Let's talk about D, densities. And the first density I want to talk about is the density of foreign bodies. Almost anything can and probably has been ingested or inserted. Some densities are not abnormal, because sometimes tablets show up on abdominal x-rays, as do contraceptive devices and stents that we put into the abdomen. But some foreign bodies shouldn't be there. So let's have a look at a few. This is a pin, a needle being swallowed, and it's overlying the left upper quadrant. It's probably embedded within the folds of the stomach and requires removement, otherwise eventually it will perforate. Look for the shape. So this, what do you think this is? Well, if you look closely, it kind of looks like a pig. So it was some kind of a metallic pig brooch which was swallowed and is sitting there in the left upper quadrant, probably within the stomach. This was a psychiatric patient who liked swallowing nails and other bits and pieces from his toolbox. I mean, it's interesting how far a foreign body can go. I mean, one of the narrowest parts of the bowel is the ileocecal valve, so where your small bowel connects to your large bowel, small bowel connects to the colon, and foreign bodies, if they haven't perforated the small bowel, they will likely stop, if they're big enough, at the ileocecal junction and cause an obstruction which can lead to perforation. Smaller ones will just pass into the large bowel. Batteries are a massive problem in children because they will let out noxious, erosive substances which can cause really bad inflammatory reactions and perforation, particularly in children. So now we come to E, which is the edges. When I talk about edges, I mean the hernial orifices, the edges of the film where the hernial orifices are and the lung bases. So look right at the bottom of the abdominal x-ray for the hernial orifices and right at the top for the lung bases. Because we miss stuff at the edges, we concentrate too much on the center. So here is the edge of the film. This is the symphysis pubis. And what we're seeing are these loops of bowel lucencies. You see these little lucencies. They can almost be thought of as lytic lesions within the bone, but actually they actually come out beyond the bone. So this is a large inguinal hernia. You can just see the edge of it there. If you're lucky enough to have the lower aspect of, the very lower aspect of the pelvis included, you can see this asymmetry of the soft tissues, bowel loops outside the abdominal cavity on the right. So this is an inguinal hernia, and lots of bowel loops on the left going down into the scrotum. So this is an inguinoscrotal hernia, bilateral. You can see the soft tissues and the bones, the density of the bones versus the density of the soft tissues. And you can actually see air within the scrotal sac, which is air within bowel. So after E comes the fat planes. So the fat planes, fat is low density, and soft tissues are slightly high density, and when fat is against the soft tissue, the margin, the interface is quite sharp. So you'll see, for example, both psoas shadows on an abdominal x-ray. because they are surrounded by fat, retroperitoneal fat. And if there's asymmetry or displacement, it might imply retroperitoneal or spinal pathology. You get other areas of fat, perirenal, perivesical, properitoneal, around other solid organs, lots of fat planes, but the psoas is normally the one we look for. The other ones often can't be seen. Here's a beautiful example of the psoas shadows, so you can see on the right and the left how the fat, retroperitoneal fat, makes the psoas shadows much more conspicuous. Okay, now we talk about the S, which means the skeleton. So don't overlook the bones, because they are actually very well visualized on an abdominal X-ray. If you see a fracture in the context of trauma, you've had a high impact, high energy injury. Bones can break, but soft tissues can tear, rupture, bleed. So if there's a fracture of the vertebral body, for example, or a transverse process or a pelvis, think about an intra-abdominal injury, and think about getting an emergency CT. Also look at the bones for bony metastases. They can be quite obvious, but you've got to be looking for them. And you don't really want to miss a cancer, particularly one that could be treated and survival might increase. Okay, so that's the basics. Let's look for the common things now. So the common things we see on an abdominal X-ray are small bowel dilatation, large bowel dilatation, and extraluminal air. I mean, that's what we see. Patient comes into A&D with abdominal distension, vomiting, not passing feces or flatus. We're thinking about obstruction, and an obstruction of bowel causes dilatation. Or if a patient comes in with severe abdominal pain, acute onset, we're thinking about bowel perforation. We want to look for extraluminal air. So small bowel dilatation, most common cause, paralytic ileus, adhesions are the most common cause, really. So there's got to be a history of surgery. Hernias, obstructed hernias, incarcerated hernias can cause small bowel dilatation. There's often an associated lump seen clinically. Volvulus, interception, masses, tumours can block the bowel, causing dilatation and inflammation. So, for example, Crohn's disease resulting in a small bowel stricture can cause small bowel dilatation. The loops will be bigger than 3 centimeters. The large bowel will be collapsed because it's a small bowel that's been dilated, and feces and gas is not getting through to the large bowel because of an obstruction. You can do an erect film where you see several air fluid levels. Here is an example: small bowel dilatation, air fluid level, valvulae conventi. These are more than 3 centimeters in diameter. Okay, so this is a small bowel loop. It's more than 3 centimeters in diameter. Here again, small bowel dilatation. You can see these small bowel loops, so many of them, overlapping each other. The distinguishing feature are these transverse valvulae conventi. This is fairly severe small bowel dilatation. It doesn't look like it's perforated because I can't see a wriggler sign. But look at the distribution. It's more central. The large bowel is essentially decompressed and just displaced peripherally. Okay, let's talk about large bowel obstruction or dilated large bowel. Most common causes are neoplasm, so colonic tumours are a common tumour, and if they get big enough they will obstruct the bowel and you'll get large bowel dilatation. Volvulus, where the bowel twists on itself. Sometimes people have a very redundant sigmoid colon. Actually, the older you get, the more redundant it gets, and it can twist, and when you've got a twist of a bowel, it causes obstruction. You get large bowel dilatation. Strictures, inflammatory strictures in ulcerative colitis, for example. Radiotherapy can cause fibrosis, scarring, and obstruction. A post-surgical paralytic ileus is where the bowel essentially shuts down because of the surgical insult, or possibly because of anesthesia or biochemical imbalance, and it shuts down and becomes dilated. It's really important because it needs to be identified quickly and treated quickly, because the large bowel is like a balloon. If it remains obstructed, it will just get bigger and bigger, and if the cecum gets to more than 9 centimeters in diameter, there's an imminent risk of perforation. You'll get fecal peritonitis, which has a very high mortality, because you basically spill feces into the peritoneal cavity and cause massive sepsis. You might want to confirm it by giving the patient some contrast or even an enema, and then you might be able to see where the level of obstruction is. So this is large bowel obstruction. Compare it to the small bowel obstruction. This is a distal large bowel obstruction. You can see really large cecum, ascending colon, transverse colon, descending colon. So it's a distal large bowel obstruction, and it's peripheral, so it's large bowel. You have these incomplete haustra, and the small bowel is decompressed. Another really nice example of large bowel obstruction is the cecum here, really widened, about to perforate, I suspect. There's a little bit of small bowel. So this is rectum here, so air in the rectum, but this isn't dilated, so there must be something going on within the sigmoid colon, because the bowel proximal to the sigmoid colon is dilated, but distal to it is collapsed. So there's probably a sigmoid tumor there, or a stricture. So this is an example of a volvulus. Basically, this is sigmoid colon, this sort of, I think they call it the peanut sign, because you've got this bit in the middle. It should be in the pelvis, but it's so redundant. It's such a large mesentery. It's twisted and flopped upwards, and that twist is causing large bowel obstruction. There's this cecum over here, which is really dilated because gas just isn't going through to rectum. One of the other causes of large bowel obstruction is toxic megacolon, and this happens in severe colitis. You get really thickened wall of large bowel with edema, and we call it thumbprinting. I'll show you an example in a second. And it's an emergency because you've got this really inflamed, thickened wall. It's weakened, it could perforate. It's a surgical emergency. This is what we call by thumbprinting. This is large bowel, this is descending colon, that's transverse colon, that's descending colon, that's beginning of sigmoid colon. And you can see the wall is thickened and it looks like thumbprint. Someone's pushed their thumb into the bowel. But actually this grey area is just thickened wall, and this is air within the colon. Really important to identify this on an abdominal x-ray. Let's talk about extraluminal air. This basically means air that has escaped from the lumen of the bowel, any part of the bowel, stomach, small bowel, large bowel, and has become free intraperitoneal air, otherwise known as pneumoperitoneum. Again, don't overcall it, particularly if the patient's had a recent surgery. Often it's peptic ulcer disease. Occasionally you get perforation from a sigmoid diverticulum in severe diverticulitis. You'll see Wriggler's sign, and you might even see the falciform ligament, more conspicuously as it's outlined by free air. You might not see anything at all, actually, because there's only a small amount of air, and it's diffuse. In this case, an erect chest x-ray is much more important. So this is an erect chest x-ray, and you can see these small curvilinear regions of free air under both hemidiaphragms. So yeah, this is intra-abdominal perforation, but very subtle sign. This is Wriggler's sign, as I said before. You can see both sides of the bowel wall being opacified. Even here on the large bowel, you can see a large sort of loop of bowel here with both sides much more conspicuous, because the air outside the bowel is now making it more conspicuous. More Wriggler's sign. Intramural air is really significant because it means that there's air within the bowel wall. There shouldn't be air within the bowel wall, it should be within the bowel. It's bad if it's outside the bowel, but it's really bad if it's within the bowel wall, because air in the bowel wall implies infarction. Infarction happens because of severe inflammation or ischemia. You can get wall thickening with it, and it can track into the mesenteric veins and portal veins from the bowel wall through the veins into the portal vein. And when you see air in the portal vein, it's a pre-terminal sign in an adult. Now here are some examples, very subtle, but this is air within the large bowel wall. It's not outside, it's not inside, it's got this sort of blotchy appearance. It's air within the wall of the large bowel, implying infarction. I know it's difficult to see. It's actually much easier to see on a CT, so if you're suspecting it clinically and you're unsure about the X-ray, please request a CT, because that will give you a much more definitive diagnosis. Here's another example of air within the bowel wall. This is the transverse, descending colon, sigmoid colon, very subtle air you can see within the bowel wall. You can see air within the biliary tree, particularly if it's had an ERCP, which is an endoscopic retrograde cholangiopancreaticogram, where they use air to opacify the biliary system. Gallstone ileus can give it to you, where the gallbladder perforates into the bowel. An abscess, particularly if it's a gas-forming organism, that will give you an air fluid level. And you can get renal tract air in infection. Here's an example of a post-ERCP. It's right upper quadrant. You can see the biliary system branching. So this is post-ERCP air. Not pathological, not portal vein. So I hope you found this very quick overview of the abdominal X-ray useful. In the last few years, we're looking at abdominal X-rays less and less. They do have a role in obstruction. They do have a role in abdominal perforation, foreign bodies. But CT is superseding them, because CT is much quicker to get nowadays. It will give you a definitive diagnosis. It is involved with a considerable amount of radiation, so should be used very carefully in younger patients. But it's some aspects of the abdominal X-ray are just completely replaced by CT. And actually, in trauma, CT rules really. You don't really want to waste your time getting an abdominal X-ray. You want to go straight for a CT. Anyway, happy to take questions. Thank you.